Alrighty. Everybody, I'm Hunter, and I'm going to be giving this presentation on sepsis management for the Tier 3 and Tier 4 medic. If you guys got any questions, just allow me to finish this current slide, and I'll just leave it open for questions. I ask that you guys try to stay involved as much as possible through the voice chat. If you're not able to, just try to stay engaged as much as you can through the text chat as much as possible. Some of our learning objectives for today are going to be consisting of understanding the pathophysiology of both distributive shock, which we have talked about in the past if you've been here for previous lectures. And then we're going to be breaking that down from there into sepsis. We're going to be talking about the limitations of 68 whiskey and just all providers may encounter while they're out in the field. And we're going to go over some of the different treatments in all spectrums of the Role 1, which we should know encompasses not only just the field, but also the aid station as well. And then we're going to go over a simulated case study at the end. Everything that we talk about today does not give you the green light to do any kind of procedures or treatments without first discussing it with whoever is your acting medical director, whether it's a PA, MD, surgeon, whoever it is. And then always make sure you adhere to any kind of policies or procedures, because we are going to be definitely going into some stuff that is not necessarily the norm, and we're going to be dispelling a lot of stuff that's been in recent literature. All right, so to start this off, distributive shock is also known as a vasodilatory shock, is one of the 5 broad classifications of disorders that cause inadequate tissue perfusion. Essentially, systemic vasodilation leads to decreased blood flow to the brain, heart, and the kidneys that cause damage to all the vital organs. Distributive shock leads to the leakage of fluid from the capillaries into the surrounding tissues, further complicating the clinical picture. And so, because of this complex disease process, the treatments for it are very multi-layered. It's also a very broad classification, as it can have over 15 to 20 different differential diagnoses. And so for this one specific thing, we're going to be focusing on just the sepsis portion of it. One thing that I like to kind of enforce whenever I'm teaching shock is to remember that there's like 4 main reasons for shock through like the hash mnemonic. So the first H is going to be hypoxic. So there isn't enough oxygen that's actually available to attach onto the hemoglobin itself. You have anemic, where the blood is exposed to enough oxygen, but there isn't enough hemoglobin to actually carry the blood to the cells. You have stagnant, where the blood is well oxygenated, but the circulation is slow and the oxygen isn't able to get to the tissues. The one big case that we talked about recently was cardiogenic shock. And then the last H is histotoxic, where the cells receive plenty of oxygen, however, they're unable to utilize it, such as a cyanide poisoning. A unique appearance to distributed shock is the wide pulse pressure, which, if we all remember, is systolic minus the diastolic, and it has to be greater than 60 to 80. I say 60 to 80 because the literature varies from what I have read, and it can actually be really useful in trying to rule out between a simple hypovolemia and other shock states that especially may be undifferentiated, which I want to try to go into in the coming weeks to months. And so the people that were here from my previous lectures on shock know that I go very deep into the patho and try to break it down as easy as possible. So here we are back at it again. Sepsis is that life-threatening organ dysfunction caused by a dysregulated host response to an infection. An infection starts when a pathogen like a bacteria, a virus, a fungus, or a parasite enters the body, and this can happen through like a wound or a cut, or it can come in through the lungs, such as in like a pneumonia or a UTI or STD through the urinary tract infection. And so the other aspect that I want to add on to is iatrogenic causes. So if we don't try to properly maintain some kind of clean field or a sterile field whenever we're doing procedures, the biggest thing that I have personally seen a lot where patients will get infections down the road is like we pop the top off of medications and then like don't really truly wipe down the top of that medication lid. So if you have the ability to do so, it's always a really nice bonus to that. And then but yeah, so the pathogen essentially once it gets into your body, it starts to multiply and it spreads and it can triggers a systemic immune response to then respond to that. Your innate immune system is your body's first line defense. Um, your white blood cells recognize that there's a pathogen that is foreign using pattern recognition receptors. And then these are going to release your pro inflammatory cytokines that then cause the fever and then also trigger an increase in white cell production. Can somebody tell me what that process is called? Whenever there's a, a regulated increase of white cell production. Not leukogenesis, but you're very close. Leukocytosis. Yeah. And then so that leukocytosis so that leukocytosis happens and then the you release immature white blood cells into the circulation and then that's going to cause a little bit of a bend anemia, I believe it's called. Um, and then these processes are very helpful at first, but they only really help the immune system try to contain the infection. And if the infection is severe or it spreads to the rest of the body, such as a bloodborne infection, your body activates a compensatory response to maintain the oxygen and blood flow to all the vital organs. And due to this, we're going to be releasing a bunch of histamine and prostaglandins, which, if we remember from our anaphylaxis presentation in our mast cell case study that we did, it increases vasodilation and vascular permeability. And so the body tries to fight this by sending a sympathetic response and increases the release of epinephrine and norepinephrine, which then causes the reflex tachycardia in an attempt to increase the systemic vascular resistance and allow for better perfusion. When your body gets down so much to the point that the perfusion starts to go down, such in right here, um, the body becomes extremely tachypnic as the cells then become very starved for oxygen, and then when the brain doesn't get enough oxygen, it starts to lead to confusion and an overall differentiated or altered mental state that is different from the patient's normal status. And if too much fluid third spaces, this is going to cause the hypotension, and it's going to be there regardless of any kind of compensatory mechanism. Hypotension is a hallmark of sepsis, mainly due to that systemic vasodilation and impaired vascular tone. And you have four main causes from it. You have just the what's it called? The capillary leakage. You have myocardial depression, and then you have a relative renal insufficiency that I'll talk a little bit about, and then you're going to have your vasodilation. And so with the vasodilation, you're going to get all of your inflammatory mediators as well as a bunch of nitric oxide and prostaglandins. And I love that meme right there. Bradykinin and a bunch of those mediators that are then going to reduce the vascular tone. That's going to cause a drop in your systemic vascular resistance. The capillary leakage then is going to be from those inflammatory mediators as well, and it's going to allow plasma to leak out into the interstitial space. And so that overall is going to be what's causing that drop in blood pressure and overall a lower perfusion state. In severe cases of sepsis, you're going to have myocardial depression as the mediators are specifically impairing the myocardial contractility. And then the adrenal insufficiency that I'll just briefly talk about. Um, it's sepsis can impair the adrenal glands and their ability to produce adequate stress hormones. Specifically, I believe it's cortisol, and so that's going to further exacerbate the hypotension. And some other normal responses are going to be like your fever, and that's due to the cytokines acting on the hypothalamus, trying to bring up the temperature in a way to like kill the infection. Um, and then it's going to increase your white cell count, and then the states of progressed infections, it's going to cause the destruction of white cells and then decrease production. Um, when it comes to the kidneys, this is going to be an open question for everybody. What is the process for the kidneys whenever a low blood pressure is detected by the carotid baroreceptors? Yes, it does relate to RAS, and yes, it's renin release. So, could any of you brave souls come up into the voice chat and explain the renin angiotensin aldosterone system? If you copy, hell yeah. Put up in here, you should be able to hop up now. If it will let you come up here. Johnny, are you able to hop up in there? Weird. Very good. I just want to make sure that this is working the correct way. You should be able to just like hop up and then it should be in there. I'm going to try to do the invite to speak and then you just accept it from there.
Oh,
Oh, there we go.
1 second.
Yeah, you're good.
Live switch device. Let's go to switch device. All right, there we go. Sorry, my headphones are messing up, and I didn't see the invite to this other side. So yeah, when you have the baroreceptors, I'm probably gonna butcher this, and I just woke up from a nap. So
You're good.
in the baroreceptors, carotid arteries is constantly monitoring that, almost like a like arterial line, like a line, and then it's going to start releasing renin, which is releasing the kidneys, which is going to signal angiotensin, which will turn into angiotensinogen and then angiotensin 2, I believe. And the point of angiotensin 2 is a really potent vasoconstrictor. And also it signals to, at the same time, it signals to the anterior portion of the pituitary gland, which is going to release ADH, antidiuretic hormone, also known as vasopressin, which is going to work on the descending loop of Henle, which is the sodium portion of the kidney loop, I guess you could say, for lack of a better term right now, and that's going to help with water retention, sodium management. One key thing is I'm sorry. It goes from angiotensin 1 to angiotensin 2 through ACE.
Yep.
Angiotensin converting enzyme is mainly located in the lungs. That's why ACE inhibitors could potentially cause ACIE, ACEI, angioedema. And I think I feel like I'm missing a lot, but that's
No,
off the top.
you were pretty much very spot on. The only thing I would change to that is the angiotensinogen is then combined with the renin and it creates angiotensin 1. And then after ACE, it combines with angiotensin 1, then it converts to angiotensin 2. But outside of that, every single bit of that was correct. So that was absolutely fire. Good shit on that. But yeah, so in sepsis, the immune response goes into overdrive. you have those cytokines release, you have the inflammatory mediators release, and that becomes extremely excessive. Instead of targeting only the pathogen, the immune response then starts to damage the host cells, and blood vessels become even more leaky on top of what has already been done from the inflammatory mediators. And then now the blood can't circulate effectively to the organs. And this causes that impaired tissue perfusion, and it just kind of starts going into a big giant cycle of spiral of death, essentially. Um, does anybody need me to kind of like explain anything easier, or does anybody want me to go into anything more in depth with this? Alrighty. So the easiest way that I can think of is if you have a source of infection, it will, and it leads to a uncontrolled systemic immune response that causes organ dysfunction, consider it sepsis. Any other questions that I can clarify on before we move on? All right, sweet. So going and diagnosing sepsis in the field, um, there must be a source of infection for us to call a patient septic. Um, After we determine that there is a possible source of infection, we need to see if the patient has some type of compensatory response. This is done through the Sears criteria, which is your tachycardia, tachypnea, and if you're rich or you have an ISTAT or something, you can get a white cell count, and it has to be greater than 14,000 or less than 4,000. And then if you have an ABG capability, you can get a PaCO2 as well. And somebody tell me what Sears stands for. Yes. Systemic inflammatory response syndrome. So, can you meet this criteria and not have a source of infection? Here, Josh, do you want to come up and talk a little bit on the peds section for sepsis real quick, just for like how you would present it in that sense?
Okay, so what did you want?
Just to talk a little bit about the peds section of it, because at least for this, I wasn't going to go into that, but just like a brief thing for it, because at least as far as I was aware, there was not a big difference.
So the big thing with peds, we got to remember, and this just kind of applies for everything when it comes to peds, is all age appropriate stuff. So we're going to be looking at age appropriate tachycardia, age appropriate hypotension, and age appropriate respirations. So you see these numbers here, like your heart rate over 100, respirations over 20. That's all to the average adult.
Yeah.
Okay. And so, you know, my 11-month-old operates in like the 120 to 40 range on a normal day. So you need to look at what your top ranges are for your age appropriate patients and go from there on this. It's I don't know if that's what you were looking for.
Yeah. Yeah.
Just had to move from another room to. So.
No, you completely understand. Okay. Um. Oh, I lost my train of thought. Can you meet this criteria without having a source of infection?
100%. Yes, you can.
100%. Alrighty. Thank you so much for coming up. And I'm gonna go a little bit into that in a little bit. But a couple things I do want to keep an eye out for is the fever, like mentioned previously, the hypotension, which is that hallmark for sepsis. And then patients will also typically have an elevated lactate, but this is not necessarily specific to sepsis. A fun tool that we can regularly use is a end-tidal CO2 monitor, whether it's the nasal cannula monitors or if we have an EMA. And if the patient is hypoperfused, that will cause a drop in the end-tidal CO2 due to the lack of oxygen that's available to the cells and an increase in the CO2 that's on the hypoperfused cells that the blood is not able to get to. Question for whoever wants to answer it. Why does the lactate go up in the body in sepsis? Yep. Yep. It acts as a buffer, right? So the bicarb buffer system is going to act in on that, but I'm just more specifically talking about like why the lactate goes up. And so um, the big thing is in low oxygen conditions where oxygen is not getting to the cells, your cells switch to a anaerobic metabolism or glycolysis, and this produces much less ATP and produces lactate as a byproduct. Which, if we have a drop in ATP because of this, which aside from the increased lactate, but when we have this drop in ATP, what is something that can also occur that we could see in sepsis? Yep, hyperperfusion, shifts in metabolism. But there's one thing specific that I want to kind of point out on, and it's going to be very important when we go into other classes as well. All right, so the drop in ATP is going to cause hypothermia because your body uses the oxygen to be able to create energy, and so if there's less energy production that's happening over time, you're going to become hypothermic. Which, to keep this in mind when we start moving later on, especially I want to try to go into the a hemorrhagic shock presentation the coming weeks. The same thing's going to happen there as well. So if anybody ever asks you like what causes hypothermia and trauma, you can give an even more baller explanation to them. Just they lose their ability to regulate their core body temperature and stuff like that. So um, the other thing that I want to bring up with as well as Sears, the sepsis and then sepsis SOC criteria were chosen by a panel of experts that was not prospectively or retrospectively derived from any kind of large scale studies. Um, there used to be a term of severe sepsis, but in my personal opinion, I feel like that's kind of redundant since any septic patient is considered a critical patient. And so um, I feel like it's just kind of throwing in an extra thing that can lead into confusion. There is a bunch of controversy over the sensitivity and specificity of the criteria, even though they have been very widely adopted all across the world. Sears is, I believe, the most commonly used pre-hospital screening tool to identify patients that are at risk for sepsis or septic shock. Which, funny enough, as once again, it's not been validated in any kind of setting. Um, and so the clinical judgment remains very important since a significant number of patients presenting to clinicians and emergency departments can meet criteria for sepsis, but do not require going through further screening and management. An example of this is a 21-year-old healthy male with a viral illness that can present with a fever and a little tachycardia and mild tachypnea. While this patient meets the definition of sepsis, you could easily argue that further investigation and aggressive interventions are likely unnecessary if the patient is appearing GCS 15, they're all right, they're overall very healthy, and they don't have many comorbidities, and so they may just require minimal treatment, maybe just some antibiotics, fluids, and be able to be sent on their way within the same day. Does anybody have any questions or comments before I move on? Whale boy, I find it so funny that you put the smog in there because I was about to just pop up on that. Cross patient who is hypothermic. Yeah, so that low temperature, if they're presenting with the other signs and symptoms of SEERS, if they're hypothermic without a really known cause, or they're sick, or they're hyperthermic, you do want to try to rule in sepsis. Yes, shock index. So, with the other previous classes that I've done, shock index is still going to remain a very large portion of this. However, if you do start getting into the shock indexes of like 0.8, 1, 1.1, that's when you're really going to be dealing with some bad cases for sepsis, and you want to try to prevent that and catch it early. So that early recognition is extremely important. And so here's a snippet of my current EMS protocols. Personally, I don't like their screening because there's a decent amount of patients who I have definitely agreed that they are septic, but from a protocol perspective, we can't say that they're septic just because of the end-tidal CO2 requirements. And so personally, whenever I try to alert the hospital if I have a septic patient but doesn't meet our specific criteria, I will still go and I'll let them know, like, hey, they're meeting sepsis. They are going to be a septic patient. However, they don't meet sepsis criteria for us. So yeah. The end-tidal CO2, it can get interesting as well, because sometimes their end-tidal CO2 may be fine, such as somebody with a restrictive lung physiology, and now they're presenting with wheezing and bronchospasm and cytokine release, and it just like it's causing some air trapping, and so it just doesn't drop that CO2 because they're retaining a lot more. And so I will just say, do what your rank can handle. If you guys have a specific criteria on what you're supposed to be calling sepsis for, and then we will talk about treatment stuff here in a minute. But this is kind of just like an overall arching view. This right here is the JTS smog as of 2024, which Whale Boy, he posted up there just a little bit ago. You can see like the major difference between the military side and the civilian EMS side is a lot less further on treatment. So we're not starting antibiotics in the field just because of the fact that we can't draw labs out in the field specifically for sepsis. Maybe if things got a little bit better, then we could. But the JTS CPGs also note their own definitions for sepsis. Now, if we're going to start going into the treatments for these patients, keep in mind that this is the prolonged casualty care guidelines, and so we won't probably be dealing with the septic patients in the TCCC environment. But that doesn't mean that a previous infection may be worsened by a traumatic event, or you have a trauma patient that was previously sick. So maybe somebody crashed a car, for example, because they were extremely sick and they began to have an altered mental state, and then they crashed their car. So do kind of keep that in mind. At the end of the day, any patient who is suspected of having sepsis does need to be evacuated. All right. I will do a little bit of a 5-minute break before we start going into anything further. And then if you guys have any questions, feel free to pop up in here or feel free to type them out. We can all kind of have a discussion over the little break. You know, Cam, it very well could. So that increased lactate is going to oh god, if I oh god, that's starting to go down yeah, oh god, what's it called? It has to do with like pyruvate Krebs cycle. That's what I'm thinking of. I think once it starts breaking down within that cycle, I think there is going to maybe be some more free radicals, but somebody else would have to quote me on that. And my computer shut off. I'm gonna kill you. But yeah, I if somebody has any idea from that perspective, I would love to see any from there. Anyone answer this? Hell yeah. How does BG? Um. So it's a combined thing with like stress, the increase of insulin resistance. So they're in trauma patients and just sick medical patients in general. We're not really going to be seeing it like pre-hospitally so much as it is like in the hospital side of things. Um, but there's a stress-induced hyperglycemia, and I would have to look up how that whole regulation cycle happens, but I believe it's similar to how um, if we go back up into here, um, it's kind of that relative adrenal insufficiency kind of thing. So the um, when the body's adrenal glands are impaired, they don't produce the adequate stress hormones correctly, and so I'd assume you have an increase of that. You have an increase from your adrenal glands secreting epi and norepi, which both of those are going to have alpha 2 effects that are going to increase insulin production. And so that can cause a drop in uh, cause a drop in blood sugar. Also, I don't know. Maybe somebody else would be able to answer that. That would be my best guess. The drop, I would say the best guess for the drop would be the increase in epi and norepi as a reflexive response. Yeah, like Tay said, it's going to depend on how far along the disease process is. All right, so we will go ahead and start it up. So they're septic. Now, what do we do from here? First, we have to make sure in the combat environment that all of march and pause is done. Make sure that we do have IV access, and then we're going to be talking a little bit about fluids. So, question for you guys: what IV size should we get specifically for the septic patient, and does it really matter? 18 AC if you're pushing pressors. Yeah, pressors always did say 2 large bore IVs. Yeah, so we do want to try to get large vascular access because potentially we're going to be giving a lot of fluid and we're going to be giving laser pressure support. Um, and so, per the prolonged field care guidelines, severe infection is often a greater risk than trauma in the prolonged environment. Trauma associated sepsis is an important subset of sepsis in the military population for potential for casualties to develop, uh, with the potential of casualties to develop a severe wound. And so the manifestation of sepsis in the trauma patient is often several days after the initial presentation, which makes it very relevant for that prolonged casualty care environment. And so by the time that you start seeing the signs and symptoms of it, you shouldn't be thinking of this within the first day or 2 days. This is something like you're holding a patient for roughly up to a week, and you're going to be seeing on like the third, fourth, maybe fifth day, where it's like very hit you in the face kind of present. I see Johnny's typing. I'll let him type real quick. We will talk about that on the next break there because I will go down a rabbit hole otherwise. Um, so our initial early treatments are going to be that early suspicion and the recognition. We're going to try to identify the source, which we're going to be talking about here in just a little bit. Early microbial therapy. We're going to start our resuscitation. We're going to try to control the source of infection if we can. And then the big thing is going to be trying to evacuate them as fast as possible and do a telemedicine consult. And so, with our step one being source control, we have our like kind of 5 main sources for that, right? If we gather a complete patient history of recent illness or ongoing illnesses, that may not be enough just to be able to say, kind of like, hey, if we're going to do just a OPQRST or a sampler history, um, it might not be enough. And so we're going to have to dig and dig and dig and dig. And especially, I know at least in civilian EMS, recent travel is not a big thing that's kind of asked. And so in these deployed environments, you do want to see if there's any kind of recent travel, maybe from country to country between service members, or if you have patients that are local nationals that like, hey, they're traveling to other regions and then potentially picking up something from there. And so we got to start with getting that pertinent negative list going if we can. Stuff like recent oral intakes, it may be good to know, but follow up like with where did you get your food? Has anybody else been sick and or been eating the same food? Or if you tell your patient if your patient says that they traveled somewhere, like go immediately and try to check and see if there's been any kind of local outbreaks or diseases that the public health officials have put out for notices. A good example of this was Flint, Michigan, where there was water contamination and it caused a massive amount of people to get sick and even died from that. Yes, it's like this isn't necessarily the best sense of like infection control, right? But the point still stands. You want to get a full history on your patient, and then sometimes finding out what the source of infection is can be a little bit more than just like, hey, like maybe that source of infection is just a pneumonia. Like try to figure out where they potentially got that. Do a good thorough head to toe exam, looking for any kind of evidence, like physical evidence of infection, such as like wounds or bites. And then be sure to examine the genitals and the rectal region if needed, because these are very common sites for missed infections. Mainly because of the fact that like nobody really wants to go look at somebody else's genitals. But if you're really concerned about an infection and you're looking everywhere on your physical exam and you can't find anything, maybe it might be worthwhile to look down there. Depending on your environment, consider performing like a rapid test for whatever local diseases, such as like malaria, dengue, and then like do different point of care source tests in an endemic area. And then you can also do like a urine dipstick or ISTAT labs if those are available to you. If somebody does have an iatrogenic cause, such as like phlebitis from an IV site, what are we going to do with that IV? Right, we're going to be taking it out, and then we're going to try to get a new site of access. Ideally, if it's on one side of the arm, we want to try to go to the opposite side, so that way then we're not screwing up that arm if in the event we do the wrong thing and then just causes a second set of phlebitis or bad skin reaction or vein reaction. A very large, significant minority of sepsis, I think is around 15% when I last looked it up, is due to fungal infections. In that prolonged casualty care environment, infections are probably going to be followed up with your penetrating abdominal trauma with kind of like bowel seeping out into the abdomen, while invasive molds and other issues can start to arise from like blast injuries with devitalized tissue, such as like let me think of an example, like a lower extremity amputation, for example. And then therapeutic options for both scenarios are going to be very limited. And I'm so sorry for my cat. She caught a sock. And so a therapeutic option for it's going to be very limited, but that's why we want to try to get find out what that source is. So if it is a parasitic infection, we want to try to attack it with the antiparasitics. Bacterial sepsis is probably going to be the most common due to the number of pathogens, to include streptococci, staphylococci, and then like various different types of gram-negative bacteria that forms in the gut. And then the treatment of these is very, very complicated, especially with the rise of antibiotic-resistant bacteria. And so combine that with the medic having a very limited spectrum to what antibiotics that they can use, typically to like ertapenem or ceftriaxone. A broad spectrum is what you're probably going to be most used to using, as well as it might be the only thing that's available to you, and sometimes it may not work. Depending on where you are, malaria and dengue fever should also be considered and treated aggressively, as well as try to have them quarantined so that way then they're not spreading that to somewhere else. Does anybody have any questions before I move on? So I do believe that we should have access to antibiotics in the field, but I think if we're going to have access to antibiotics in the field specifically for EMS, we should be drawing labs before giving those antibiotics. Because if we were to give antibiotics before drawing labs, or if we did it vice versa, where we gave the antibiotic and then draw labs, then it could skew the test results, and so it's not really good for patient outcomes in that point. So as we start going deeper into the CPGs, looking at these, we do have a few different options. For microbials, it's pretty straightforward. In a perfect world, you use two separate antibiotics, a bacterostat and a bactericide, which, if you remember, a bacterostat or a stat is stopping the replication process of the bacteria, and then the bactericide is something that doesn't necessarily stop the replication process, but tries to kill the bacteria before it has time to replicate. And so by combining the two of those, it not only disrupts the reproductive process, which will eventually kill the bacteria, but then it also somewhat works at killing stronger bacteria as well. Ertapenem does both of these, so it's a pretty solid to use it. And it's very widely available to most combat medics, and it's also in the CPGs, at least for TCCC. And so it's going to be something that's very, very common, that is pushed out there and medics are familiar with. Parasites can be very, very complicated, and I personally have no experience treating these. So a lot of the information that I can give is based on the JTS guidelines and just doing a bunch of research on my own before giving this presentation. If anybody does have experience dealing with antiparasitics or any kind of parasitic infections, I would love to pick your brain about that. And if you wanted to come up here and talk about it, I'd love to hear it. But depending on the region, if, say, for example, malaria is around and you're unable to test for malaria, empiric anti-malarial therapy can be considered if there's no response to antibiotics, for example. And then, in all honesty, me personally, I would not screw around giving a whole bunch of different medications unless I had telemedicine available to me. Per the CPGs, whenever advised to by somebody higher, you can combine antifungal drugs in conjunction with the antibiotic regimen, but I wouldn't just go and do that prophylactically as like, hey, I'm going to cover all my bases. Let me answer that question real quick. So, assuming a grossly contaminated battlefield injury, otherwise healthy patient, what's a reasonable timeline that we might suspect to see sepsis? Same thing. It's going to probably be within like the latter half of 2 days, more likely not presenting 3 to 4 days. With even in the healthy patient, like there might be able to fight it off a little bit quicker, but depending on the severity of the trauma, your body's already going to be trying to fight just to keep itself alive, and so its ability to fight any kind of new bacteria once it gets into like the later stages of the days, it's not going to be fun for the patient. So yeah, appendicitis. Yeah, that will, if say for example you get a burst appendix, that is going to take your patient down very, very quickly. And so, continuing a little bit further, this is where things start to get very controversial, and we're going to be going really deep into this. So, how much fluid should we be giving to a patient, and at what point do we start to consider pressors? Okay, I see 20 cc's kilogram. Pressors and fluids together. I love that passive leg raise. I'm going to be talking about that here in a little bit. 500 mils in cess, 2 liters max. Yeah, so there's a bunch of different things that we can do, right? So surviving sepsis and the JTS tells us 30 milliliters per kilogram before pressors, or simply 2 to 3 liters of fluid before pressors. But is that evidence based? Is that based in any kind of evidence? Like, where did we get the 30 milliliters per kilogram from? Yep. CVP. Yep. Yeah. So as we start going into this study right here, we find that this was the hallmark of the idea of fill the pipes before you squeeze idea, which I'm sure everybody has heard. You had a comparison of fluid resuscitation versus vasopressor use over various different timelines. The first one was the initial 6-hour period where it combined the early goal directed therapy versus the standard therapy. The patients in the early goal directed therapy received significantly more fluids than those in the standard therapy group. There was no difference in change with vasopressor use at the 7 to 72 hour range. Once again, it's pretty much the exact same. However, there was a greater portion of patients that, there's a greater portion of patients that required vasopressor use at that 7 to 72 hour range. And then the overall period from baseline to 72, the total volume of fluid administered was not significantly different between the two groups. And then there was a greater portion of patients in the standard therapy group that received vasopressors compared to those in the early goal group. Some very big key findings on this study. The early goal directed therapy optimized fluid resuscitation within the first 6 hours, which then reduced the need for vasopressors following the patients from the 7 to 72 hour range. And then the patients in the standard therapy group received more vasopressors, had less favorable outcomes, indicating that a early hemodynamic optimization, including fluid resuscitation, may decrease the reliance on vasopressors later. And so the exact volume of fluid was titrated to a central venous pressure between 8 to 12 millimeters of mercury, and they found the average fluid administration during the first 6 hours of this goal therapy was approximately 30 milliliters per kilogram, which then formed the basis for all sequential recommendations, including surviving sepsis. This was done in 2001, and nobody has gone to try to fight against it. And there were multiple other studies to include the process study that was done in 2014, the ARISE study in 2014, and then the PROMISE study in 2015 also supported this idea. And so throughout the world, it became a staple in the care for sepsis management. However, this is buried deep within the paper, and it's buried within all 4 papers. The protocol as follows: a 500 milliliter bolus of a crystalloid was given every 30 minutes to achieve a central venous pressure of 8 to 12 millimeters of mercury. If the mean arterial pressure was less than 65, vasopressors were given to maintain a mean arterial pressure of at least 65 millimeters of mercury up until 30 milliliters per kilogram. So, what does this show, and how can this affect our care? Because if we're kind of looking at this from like a face value perspective, even in their own study, even though they recommended giving 2 to 3 liters or 30 milliliters per kilogram of fluid before starting pressors, with the idea that if they had not gotten to 20 to 30 milliliters per kilogram of fluid, then if they had not reached a central venous pressure around this range, they would need vasopressors. But in their own study, they used vasopressors early. And so, yeah, like Johnny said right there, conservative fluid is potentially a very safe option. And so, if we are limited in the environment, maybe we should be doing 500 milliliter boluses, start vasopressors early, and get that patient hemodynamically stabilized, and then wean them off of a vasopressor if we need. Because if we were, for example, if your patient is very hypoperfused and their mean arterial pressure is less than 65, and you try to give them some fluids, and let's say like an hour later goes by, you've given them 2 liters of fluid and it still hasn't come up. Well, they're still hypoperfused. And so that's an additional hour that they're going where oxygen is not getting to their cells, right? And so getting that 500 milliliters as a challenge can be very, very beneficial. And what we should start seeing after we do these 500 milliliter boluses is hopefully a change in the end tidal CO2, a change in the blood pressure, maybe a decrease in the heart rate. And so, like, I can't remember, I think it was Johnny that mentioned it with the passive leg raise test. If anybody does not know what this is, you essentially put them in Trendelenburg, and if you see a 2 millimeters of mercury spike in end tidal CO2 while having a 10-point increase in the systolic blood pressure, it is a very high likely chance that they're going to be fluid responsive. I've been able to see this very thankfully multiple times out in the field, and it's gotten so much to the point where I will bet with my partner, like, hey, I bet we're going to start pressors before we get to the hospital, even in a 15 to 30 minute time frame, right? And yeah, so it does have a high specificity and mid sensitivity. And if you look back into the studies, and I'll try to see if I can find the studies and I'll post them out somewhere. It was specifically done for mechanically ventilated patients, but the physiology still makes sense. But now we're going to go into the second controversy, which is lactated ringers versus normal saline. Who here is a big lactated ringers fan? I am very much hoping that everybody says yes. So yeah, lactated ringers is a, oh yeah, there we go. Let's see this. I will find out if somebody did normal saline. But yeah, right. So the lactated ringers is a more balanced fluid. It contains potassium, it has sodium, calcium, and lactate, which the lactate that's going in there, it's not really that much of a big deal compared to the lactate that's already in the body. Compared to normal saline, which contains mainly just sodium and chloride. And so this increases the risk of hyperchloremic metabolic acidosis, and which is another reason why, at least in our trauma patients, we don't want to just start flooding them with saline. Right? But to kind of go back on this, if we're only doing 500 milliliter challenges, it's not really that big of an issue, right? And so the other couple points of it, the pH is going to be a lot better in LR. If I remember correctly, LR has a pH of like 6.5, and then normal saline is like 5.6 or something like that. Somebody can correct me on that. But in a patient who's already acidotic from sepsis, you want to try to balance the pH as much as possible. And so if we do end up getting to the point of like, hey, we're starting 2 liters, 3 liters, maybe even 4 liters over the course of multiple days, and that's all they're getting is a pH, it can really screw them up. And then also, according to the SMART trial and the SALT ED trial, it had a lactate ringers, that is, it had a lower risk of AKI or acute kidney injuries. And then it also suggested a significantly better outcome compared to normal saline. So for the kind of the too long didn't read or didn't listen in this case, use saline or lactated ringers first if you have it. But if you don't feel scared to use saline if you need to, or just use like back and forth if you are short on supply, right? And so what about blood products? So in the trauma patient, if we have not been able to evacuate them to a surgical facility and we don't want to flood them with just normal saline or LR, right? Kind of the whole lethal diamond trauma thing. And so, however, we also don't necessarily will always have the ability to use whole blood. And so if we are going to resuscitate for a long period of time, we might be able to balance it out with alternating between 1 unit of blood and 500 milliliters of lactated ringers and saline to not only try to prolong how long we are using this blood resource that could potentially be used for other patients, or if we're doing a walking blood bank, for example, to kind of keep that in reserve for something else. But it would also prolong the amount of supplies that we are using overall. In this case as well, pressors are very, very controversial. However, we're using pressors to treat the suspected sepsis, not necessarily the hemorrhagic shock of it. And so if you're getting into the time frame of like maybe you've given multiple units of blood, and it's been like 3 or 4 days now, and they're just, if for some reason they're having a giant drop in blood pressure after being previously pretty fairly stable, you could probably justify that it's more of a septic cause rather than a hemorrhagic cause. And so mentally, it can be a little bit easier to justify giving pressors in that case, but it can also be even easier to justify during your telemedicine consults to be able to say like, hey, yes, I have this type of physiology for a patient, but I'm not necessarily doing it for this. I'm doing it for another reason. I like the anaphylaxis thing that we went over the other day. And so let's take a quick break real quick, and then we'll go into the last little bit, which is just the case study. Yeah, component therapy is in the chat. Does anybody have any questions on anything so far? Anything that you want me to recover or anything like that? Anybody want to come up and talk shit? Oh yeah. It was super, super beautiful. Did anybody need the break, or do you want me to just kind of bust through this? Because we only have 6 more slides to go. How do you feel about push dose pressor norepi? So so the push dose norepi is, I've read back and forth things on it. The half-life for norepi is very, very short, and so it isn't going to be that much of a bridge. And then considering that it has a very, very strong alpha presence, it could potentially give too much of a squeeze. And so if you were to give any kind of push dose pressor, you'd probably be better off with like phenylephrine, vasopressin, or epi. But I know there are some places that are doing push dose norepi. I don't know too much on that. I would assume it's inferior to doing push dose epi though. Which that just for this little bit, I will go on a little bit of a tangent. Which if we kind of remember the physiology for sepsis and like why we give epi and anaphylaxis, with it being a similar distributive shock state with prostaglandins and histamine release and stuff like that, we can assume that there is some type of mast cell destabilization that's happening, and so potentially epi, like push dose epi, might be actually very beneficial. But I don't know really too many studies on that, and I think that's just me going down the rabbit hole. But we'll go ahead and continue on, and then we'll just finish this up, and hopefully I'll try to be done in like the next 10 minutes or so. Alrighty. Yes, let's talk about whole blood.
I think I got working this night. I had to just DC my freaking headset. It sucks. So I was actually just talking about the whole blood thing with the comprehensive medical training I was at a couple weeks ago. So full transparency, like, I have not taught the 68 whiskey MOST when they were incorporating blood products. We were still talking about Hexten, even though it killed my soul. But pray doc going pray doc kind of situation. And I foresee a huge training scar, and I was actually talking to Ryan McCraney about this the other day, where we're going through the CCA, and they're like, IVS for like whatever vascular access, low titer O negative whole blood. And I was like, I feel like people are just saying these words and they
but
don't
not
understand.
not truly understanding.
And so I posed a question, and this is for the group as well. It was like, when talk about low titer O negative whole blood, and I was like, questions that you should be asking yourselves before you even get to that point is, what kind of fluid warmer are you going to use? When's the last time you set up trauma tubing? Why would you use trauma tubing versus just a regular drop set? Well, why or why not would you use suspension fluid? Do you even use the suspension fluid for whole blood? What warrants whole blood versus component therapy for this patient? When's the last time you QC'd the batteries on that fluid warmer? What is your flow rates for fluid warmer on your particular fluid warmer? Because I'm used to the Quinn flow from the critical care side on a civilian job.
Yeah.
And it was like, we can push through a lot, but it's like we have to have a certain the extended battery versus like the regular battery. So it's like, do you know that for your thermal angel or for your warrior like Quinn flow or whatever product, or are you in roll 2? And it's like, and you can dump a liter of fluid, and since it's hot wired into the wall, you don't have to worry about the batteries dying. It's like, when's the last time you LDON carded the recipient and the donor? I was like, how many times has that donor been used for a walking blood bank? So I think people hear whole blood and it is sexy. I was like, well, I postulate and posit, I guess the word really is like, I don't know this with any kind of certainty, but I've been in the game long enough that I foresee, like within the conflict Lisco and all the those buzzwords and such, is like, as we move forward into those new combat environments, we're looking at, hey, welcome to country, give us 4 units of blood because we're going to centrifuge it out and we're going to make a bunch of different component therapies. So to your point before, it's like, does this patient really need whole blood, or do they need FFP or freeze dried plasma? It's like,
plasma light and
people
stuff
are like, well,
that.
why would you do that? And I was like, well, you should know that. And it's like, you should know, it's going to give you about 300-400 cc's of volume, but 80% of that's going to be clotting, 20% of it's going to be clotting factors. And it's like, so what does the patient need at this time? I was like, is this a volume issue or is it a pipes issue? And it's like, okay, well, maybe we should start some hemoactive agents first before we start digging into this precious resource of whole blood.
100%. And I think the one big thing that a lot of 68 whiskeys don't realize as well is, if you're giving, say, for example, packed red blood cells, it's not going to be as much of a pressure increase as it is if you were to give plasma, because the volume is in the plasma. And so you're going to give that, like, yes, they're going to potentially get a little bit better oxygenation, but it's not going to be so much of a pressure increase. And so I think there was a study that was done a couple of years ago, and I think like 2021 or 2022, that showed that there was no difference in packed red blood cells versus normal saline in pre-hospital trauma. And so it's kind of interesting because, like, yes, it's blood product. It's a wonderful thing to give, but like we're not giving all three components that the patient needs. And then even in a septic patient, maybe they are anemic and they don't need full component therapy. Maybe they could just use um, packed red blood cells to replace the anemia and then a little bit of extra plasma and focus more on the plasma side of things after the anemia is corrected. And so,
And that brings up the point of like suspension fluids. Like, okay, well, ideally you would want to use LR or plasma light because of that balance profile. And say, okay, well, that's going to be your little bit of volume on top of a PRBC. And it's like, well, that could maybe meet the intent depending on the patient and what we're looking at. But you rustled on Jimmy's very hard with that slide, and I was like, I need to,
oh yeah,
thank you for entertaining my TED talk.
oh 100%. Alrighty, I will try to knock out the rest of this super quickly, and then we'll call it a day. But alrighty, so for the case study, you were deployed to the South Sudan as a part of a humanitarian team, and some locals bring you a 43-year-old male who had a 5-day history of feeling hot, abdominal pain, generalized weakness, and a loss of appetite. On the initial presentation, he appears very weak and lethargic. Conjunctiva are pale, and the eyes are sunken. What are our initial thoughts on this patient? And then based on the region, what would be some initial concerns? Yeah. Scene safe, PPE on. Absolutely. Yeah, potentially dengue fever. What else? Maybe like malaria, maybe typhoid. Maybe it's not even any of the fevers. Maybe it's just a older man who he's just been feeling a little sick and he doesn't want to eat. So yeah. So now, as we start to go into the vital signs, the heart rate is 67. Blood pressure is 72/20 with radio pulses present, but they're weak. Respirations are 24. SpO2 is 92%. BG is 62. And temperature is 102.1. And so, what are our thoughts on this patient after we get a set of vital signs? And I know the shock index there, but is there any kind of fever that has a relative bradycardia? Ignore the back of this. Yeah. Yeah, so potentially things like typhoid. So typhoid could be potentially very high differential on this. So seeing if they are up to their vaccinations, if there are any vaccinations that are able to be given out. Yeah, pneumonia, yellow fever. Is the blood glucose an issue? Is this suspected of somebody who hasn't been eating for the last couple of days? Yeah. Yeah, you probably expect it to be a little bit lower. What about the SpO2 with the respiratory rate? Yeah, normal for having a civil war. Yep, end-tidal CO2 is going to be very good too. And so, what is the pulse pressure with this? Yeah, 52. It doesn't meet that kind of like wide pulse pressure thing of 60 to 80. No, but you can't get real much lower than this, right? And so even though it doesn't necessarily have like the wide pulse pressure, maybe it's still something to kind of think about with that diastolic, because that diastolic is still extremely low for the systolic being where it is. Typically, if you had somebody that had a pretty average pulse pressure, it'd be like 72 over like 35 at the lowest, or maybe around 40s or something like that. And so you start giving O2 through a nasal cannula that you have at 4 liters a minute. You got bilateral IV access, and your cultures were drawn. 500 milliliters of normal saline, or not normal saline, but lactated ringers was bolused, and then there's no change. What can we do now? The conjunctiva being pale does mean that he's not perfusing well. Yeah. Another 500. ELR. Yep. And so you start another 500 of lactated ringers, and you begin to start up a presser as that is going in. Your junior medic gives 2 grams of ceftriaxone and a Tylenol for his fever. We're going to do a little bit of med math here. I know people are going to kill me for this. But you have a 250 milliliter bag of normal saline. How much of the medication are you drawing up if you have 4 milligrams of 4 milligrams and you 8 mics a minute drip rate? I'll let people give that time. And then I'll give you guys a fun trick afterwards. Yeah. So the bag concentration is going to be 16 micrograms per milliliter. And so now we take that and we want 8 mics a minute. What is our drop rate? Yeah. Drop set's going to be 60. Because if you were to do a 10 drop set for something like this, your math is going to be all kinds of fucked up. Yeah, 30 drops a minute, right? And so, fun little thing. Typically, if you were to start doing a epi infusion, say from like a 250 bag of normal saline as well, your concentration is going to be roughly the same. And so I know there is some ideas with like taking 1,000 bag and throwing like 1 milligram into 1,000 bag for epinephrine. For medics who may not be really proficient with norepinephrine or know how to do drip rate calculations and stuff like that, potentially doing a very diluted out presser and then titrating that to a radial pulse or a femoral pulse would be acceptable in the environment where you don't have a provider that is extremely well versed in pharmacology. And then just a quick way, if you want to know your concentration, and it's going to be the 16 micrograms per minute if it's the total bag's concentration, just divide your drip rate by half. So if we remember the clock method, whenever you talk about like lidocaine and stuff like that, you can use that for every medication that you have a drip rate on, right? So if you have 16 mics a minute for 1 drop per second, if you divide that by 2 and just have 1 drop every 2 seconds, it's going to be 30. Divide that by 2, 1 drop every 4 seconds, that's going to be 4 mics a minute. Divide that by 2, and you can see how like if you get laughs and dopamine clock, you'll see kind of how it's going to be a little bit quicker and easier to do all these calculations. The easiest would be if you just had a pump, but we're Not always all that lucky. And so a couple hours go by and you start to reach the max of your first presser, right? So your first hour goes by, you start doing this, you increase the norepi to 12 mics a minute, you give it a total of 2 liters, and then you've gotten up to 16, you've increased to 20, and then there's still not really any kind of change there, right? Like maybe you got a little bit of a good heart rate change, but even with your systemic vascular resistance increasing, or not your systemic vascular resistance, your cardiac output, it's increased, but there's no change in that systolic or that map, right? And so, what is your guys' solution to this? Like, are you guys comfortable mixing pressors together? Not just like, hey, we're only going to do norepi or we're only going to do epi. And then, like, kind of like think about like what's the risk of adding multiple pressors? So yeah, like maybe a vasopressor infusion. So, Artie, if you did a vasopressor infusion, what's the risk? Yep. Shorter half life in acidotic patients. So maybe that's what's going on here, right? Maybe just it's not as potent. And so, if, say, for example, norepi was the only pressor that we had available to us, but we have a steroid, could doing like hydrocortisone or dexamethasone potentiate the effects of vasopressors? Yeah. So there's a study that I can post out here in a little bit, where if you have hydrocortisone, it can be very useful in patients that have refractory septic shock to vasopressors. Yeah, and Rob, don't worry about it. We're just getting ready to finish up here. But yeah, steroids have that potentiated effect on vasopressors. There's the big risk with vasopressin is the half life of vasopressin is, if I remember correctly, like around 15 minutes. So it'd be a wonderful push dose pressor to like stabilize somebody while you're getting ready to do a bunch of interventions. But if you were to do an infusion of vasopressin and you get the initial dosage wrong, you could potentially have a very hypertensive patient. Or if think about like whenever you're first getting the drop rate down, if you had accidentally bolused a little bit because the patient kinked their arm. Not saying I have done that, but I am not going to confirm nor deny. But other medications like phenylephrine are doing like a push dose epi or doing additional medications. Like it can be very beneficial. And even though typically in most places will max out at 30 mics a minute for norepi, there's not a whole lot of evidence that says that you can't go past that. And so if you needed to continuously keep going higher and higher, theoretically you could do so, but now you're running the risk of tissue ischemia. Now you're running the risk of end organ hypoperfusion and ischemia. And so you kind of need to weigh the risk and the pros and cons and stuff like that, right? But at the end of the day, whatever you guys decide to do, telemedicine is never a wrong answer. So just keep that in the back of your minds. And then we will kind of call it up from there. That's kind of it for today. I know it was a little bit on the longer side of things, but I hope everybody got something out of this. If you guys have questions on stuff, feel free to reach out to me. And if I don't know the information to something, I'll try to get that info out to you. And then in the coming weeks, I want to try to do potentially like a neurogenic shock or probably I'd do like neurogenic shock or something like that. And then My wife, who's a labor and delivery nurse, she wants to do a presentation on labor and delivery stuff and just like OB emergencies and just overall OBGYN stuff. But yeah. Other than that, if you guys have any questions, just I'll stay here for the next couple minutes to try to answer those, and then we'll be popping out of here. Alrighty. Absolutely, guys. Alrighty. I will see you guys later.